So these are the disorders we're considering, and we're talking about lower GI. And these aren't necessarily super common, we're in the lower area for MP3 when it comes to GI stuff. We do have another GI lecture for exam 2 where we're going to talk about liver and pancreas, so that's coming later. But we're talking about digestion, small and large bowel. So what goes on in pediatrics? These are the common lower GI type disorders in pediatrics, not that they are that common. I would say probably pyloric stenosis out of these is a little more common than the others. So more specifically, it's hypertrophic pyloric stenosis. So you probably can figure out, just breaking down your medical terms. Hypertrophic, what does that mean? Hyper, more. Trophic is in that size, right? A hypertrophy, an enlargement. Pyloric, so it's of the tissue in the pylorus area, right? So that opening from where the stomach empties into the small intestine or the duodenum, right? So there's a hypertrophic of that tissue, which causes a stenosis or a narrowing in the opening. So that's what's going on. That's a stock photo, that's not my kid. I had to dig back, my son's gonna be 18 in December. I was like, I don't even have his baby pictures on my Facebook because Facebook wasn't even around then. So I had to really dig to find some pictures. I left him out. Plus I don't think he wants his picture up with pyloric stenosis. So what is a pyloric stenosis? We talked about it. This is what that looks like, that thickened muscle and that narrowing, that stenosis. So hypertrophy is an enlargement, and stenosis is a narrowing. Okay? So that's a circumferential muscle, a little sphincter in there that allows food to go from stomach into the intestines and move along. So it creates an elongation in that pylorus. So it's normally, not a huge area, but with that swelling, it kind of stretches it out. So sometimes they can see that on an x-ray. So this is something that happens in littles, 2 to 5 weeks, right? So we see this kind of early. Males are more affected than females, about 4 to 6 times more often. They're not sure why, it just is the way it is. And in full term. Why do you think that is? Why would you think full term would be? Think of your preemie, they're still developing, right? So it would, if they were to develop something, it would be a little bit later in that. So they're a little bit further along if they're full term and everything's kind of grown at that point. So then there's been enough time for that overgrowth to occur. And Caucasian. So over here it says this non-bilious vomiting. What does that mean? Non-bilious? Absence of bile, right? So think anatomically, if that pylorus is shrunken and stuff is having a difficult time passing into the intestine, where does bile come from? Gallbladder, which empties into your small intestine where? Distal to the pylorus. So a little further down. So it empties into the duodenum or jejunum area. Duodenum. So the pylorus is more proximal to that area. So if we've got a blockage, let me go back to this picture. So bile enters the bowel distal to your pylorus. So if this is occluded, we've got backup here, right? So vomit's not going to have bile because there was no way for the bile to get into the stomach, right? So it couldn't pass through here. Does that make sense? Yeah. So if you see bile in the vomit, it's probably not pyloric stenosis. That just kind of helps you think critically through what you're seeing when they make a big mess. It's progressive, so it can get worse, and it's projectile. I mean, that green bucket from here. Yeah. The cartoon's not kidding. A little pacifier, a little pressure behind it. So projectile vomiting, non-bilious. Constant hunger. Think about what's happening, right? Whatever goes in gets to the stomach but doesn't go any further. So they're constantly hungry. So they throw up and they're like, give me more, right? Versus a baby who just spat up because they had a full belly, they popped the top, right? They couldn't fit anymore, it came back out, but they're pretty full. Babies who spit up aren't going to be projectile, there's not a lot of force behind that, right? So constant hunger is another hallmark sign. They just can't get, they're not, the food's not getting there where they can absorb those nutrients, so they're starving. There's an olive-shaped mass in the right upper quadrant. That was from your Kahoot, right? No other place in an NCLEX exam will an olive-shaped mass be anything but pyloric stenosis. I don't know why. There's a lot of things that are shaped like an olive, but that's what they pick. So olive-shaped mass in the right upper quadrant. Why in the right upper quadrant? Think about anatomy, right? Distal to the end of the stomach puts you right about here in that right upper quadrant. You'll see a peristaltic wave. That's what one of my videos is. From the left to the right in this direction. So I'll show you a video. We can talk about why. Failure to gain weight, because they ain't getting nothing, right? It's coming right back out. And of course, signs of dehydration. This is your pediatric fluid and electrolyte presentation, basically. Fluid losses, from vomiting or diarrhea, is super, super fragile in children. They cannot tolerate losses. They will go downhill real quickly with dehydration and metabolic alkalosis, which we'll get in when we talk about fluid and electrolyte. But it's a big deal. Dehydration makes kids sick quick. So this was the video. Oh yeah, this one YouTube wanted to block me on because of vomiting, because it's not appropriate for the internet. But does anybody, I want you all to be able to see it, at least if you're at home. Do you get the little YouTube? It's not even showing up. I embedded it. Maybe I tried to go too fancy on it. But this is a video of projectile. I'll fix it for you in case you want to see. But it's I think it's like a TikTok video or something. But the mom's like talking to the baby. Oh, he loves his poppy seed, and oh, he's just so happy when he's in it. And she gets the mess. So it's just what it looks like. It's pretty characteristic, and he looks a little like irritated at first. He's just kind of just a little slight little. You can see him kind of scrunching in, and then boom, pop the lid. This one's a video too. This is a peristaltic wave. You can kind of see. I know it's not on that upper right side, but this is like a little bulge. It's not that olive-like mass that we're talking about. It's basically it's like stomach contents, and you'll see what looks like a wave. This piece just looks like it moves across the abdomen. I think I've got a video pulled up. Let me try to get out. Show y'all. I'm having the worst luck with technology these days. So let's see what this video shows. Seems a little close up. So you might see a left to right. Yeah, there it is, right there. Creepy, right? Aliens. So, and there's a little time, lag in between. I don't know if this one's going to show you some more what it looks like, but yeah, there it goes again. Classic peristaltic wave. You can see his respiratory rate a little bit too. A little discomfort perhaps. Probably pretty hungry. Surprised we don't hear him upset because he's wanting to feed. Alright, so that's a good video of peristaltic wave. So what's happening in that wave is the stomach is trying to force everything past the pylorus into the duodenum. So you're watching the stomach peristalsis trying to force, and it just doesn't go anywhere. Yes, that's why it's that left to right. So you know your esophagus and your stomach is a little bit to the left side, and the duodenum, it exits this way to then go around, and then lower right up into the colon, all the way out. So the direction of flow is a good thing to have in your mind of how things work, and that's why that makes sense on assessment. If that stomach's trying to force everything through that pylorus, you're going to see that peristaltic. It's not so important to know left to right, right to left. It just makes sense when you see it on somebody, because you're not usually going to see peristaltic wave unless maybe there's some obstruction somewhere. They're going to have different symptoms, right? I've never seen it in anything but pyloric stenosis. So the olive-like mass, so that's that hypertrophy that you're feeling at the pylorus. That's why it's in the elongated, feels like a long olive, little round mass. That's what it feels like. Vomiting occurs 30 to 60 minutes after eating. So you might see that peristaltic wave, it's trying to force it along, it can't send it, and now we're overloaded and out it comes. So projectile as obstruction progresses. Ultrasound can show this elongation, right? Sausage-shaped mass. And that pyloric canal is narrowed. So of course, your labs, right? Serum electrolytes are going to be off. Right? They're not getting those nutrients. And they're losing fluid losses, gastric contents too. So which electrolytes are going to be off? Sodium. How is sodium going to be? Blue. Yeah. Potassium? Say again? On potassium? You're thinking inverse. You're going to have equal losses too. You're going to have lose that as well. What were you saying back there? No? Chloride, right? So it says insignificant and caught early. So if we recognize we've got this pyloric stenosis thing going on, and we can get them seen by their provider, they may not have lost enough to really cause a serum change in their electrolytes. But if it keeps going and the parents just thought, oh, I just overfed them, which then causes them to not try to feed them as often, to a kid who's already starving, they're going to have weight loss, then they're going to start to have those electrolytes starting to change, and we can end up in a metabolic alkalosis. So we lose that acidity, and now we've got some other problems. But that's later, that develops over time. If you're losing the gastric contents too, you're losing, you're losing all of them. You're thinking about a cellular shift in electrolytes and kidneys. So preoperatively, we want to rehydrate, right? This is if they've been dehydrated. If this has gone on long enough, we've got electrolyte losses and fluid losses, we've got an imbalance in their fluid and electrolytes. They're going to rehydrate them first. So this is going to delay that surgery for that reason. We may do the NG tube or the NJ if they can. They probably can't get it passed, but they might try to do that just to kind of rest that area. But again, if that pylorus is narrowed enough, it's probably not going to be effective. And then intraoperatively, they're going to do the pyloromyotomy. That is a surgical procedure. They can do it laparoscopically. They don't usually open them up unless they have complications. And this is just showing like just where they would put their little punctures to get in there and fix that. And I'll show you, I think it's the next slide. But post-operatively, we're going to ease them back into feeding again. We're not going to just, especially if they've done surgery on a sensitive area that needs to do some of that digestion. There's some healing that's going on there. So we're going to do some clear liquids first to not irritate that area until we can have a little bit more healing and advance their diet from there. So at least we're going to be working on hydration. It's not to the point where we need to do TPN unless they're severely compromised or there's some kind of failure to thrive. But they'll look at that case by case. But usually we'll just go to clear, some Pedialyte, and then we'll start advancing into their formula from there, or breast milk. Breast milk's a little bit easier, there's less, and especially if they're younger, if they're only a couple of weeks old, there's not a lot of fat in that, a little easier to digest. Okay, so it's just another memory graphic for you of what some things are gonna look like in the orders. NG tube, replace drainage with, yeah, this isn't as important. This is just FYI, the half normal saline. So they're just gonna do fluid replacement. NPO, strict eyes, nose, they'll have an IV, they'll get daily weight, and an abdominal girth. Why an abdominal girth? We wanna measure, right? We're looking for abdominal distension, right? So we wanna see where they are preoperatively, and then how much that's changed postoperatively. So post-op, they come out of surgery, we're gonna have them on the right side, head of the bed elevated. Why the right side? I know you're thinking it. Think of direction, that's what I'm talking about. Think of the direction of traffic, which way it flows, right? So this is in the post-op, so as we're starting some clears back on them, we want to let gravity kind of help some of that go through, right? So we don't have to have that peristalsis work so hard to push things along. So right side, head of the bed elevated, why? Hydration, well, we're trying to keep them hydrated. We don't want it to come, is that what you said? I'm sorry. That's not what you said. Aspiration, there you go. Right, you guys know this, right? Just get your confidence back. I'm sorry, I misheard you. Okay, assess the incision site, nothing new on your post-op care. Steri strips are going to be over the mid-abdomen. DSD, dry sterile dressing changes needed. Usually with laparoscopic surgeries, there's not much leakage at all, if anything. We're going to continue the I&O real close, real strict to eyes and O's at daily weights. Are they regaining weight? Are they getting rehydrated? And abdominal girth again, right? Let's compare. Where were we before? Are we improving now? Have they distended? Have they relieved that distension? There may be some initial swelling. It's not going to be something right off the bat, but not typically a whole lot. Slowly introduce when bowel sounds are present. So anytime you do any kind of GI surgery or surgery in general, the bowel goes to sleep with anesthesia. So we want to make sure that that's moving again before we throw stuff in there, right? So listen for bowel sounds before we start those clears and get them back to eating again. Don't worry so much about that. This is just an example of what an order might look like. 15, and we don't use cc's anymore, we say mLs, 15 milliliters, D5W, Q3 times 3 feedings, and 15 cc's, half strength of formula. Just an example, kind of see what it might look like. Any vomiting, they would hold their feeds, of course, because then that's probably something with, not that the surgery wasn't effective, it just could be part of the anesthesia, recovery, but we don't want them to aspirate that, so we want to keep their belly empty until that's resolved, until they can figure out why they might be vomiting again, and then we'll return to the previous volume given, right? Because maybe that volume was too much until some of that post-op recovery occurs, so we'll go back to a lesser volume until we reach our goal. So there's often a goal in peds when it comes to volume and what they're feeding. If we don't want them to take a full feeding right away, they'll have that in the orders. What are we working towards, and how soon are we going to advance that diet? So it's a little more specific in peds than in adults. You guys might have seen like orders that say advances tolerate. Right? This is kind of like that, but they're a little bit more specific as far as what's our end goal. Because depending on their age and their weight, whether they're breastfeeding or whether they're on formula, is going to determine what those goals are. All right, so that's pyloric stenosis. Pretty clear cut. I thought I had a picture in there to show you what it looks like, but basically what they're going to do is they're going to cut through some of that to relieve some of that pressure and tissue and open things back up again. All right. Bowel within a bowel, intussusception. I don't know how they come up with these names. Alright, so you guys got that on your Kahoot. Condition which part of the intestine telescopes into itself. Yes, it's an emergency, right? Why? Why is that an emergency? Why are we so worried about that? Cuts off the blood flow, right? That's the problem with an ileus. It's basically a blockage, complete blockage, and then we lose our blood flow with all that pressure in that area. And the cells in that area start dying and we can't bring them back. Once they've lost blood flow and that tissue starts dying, we need to remove that part of the bowel, no matter what the bowel disease is, right? So we got another sausage-shaped abdominal mass, red currant jelly stools. I know you. That's what it looks like. That's some of that bleeding that's going on, right? It can be fatal because of the decreased blood flow and the sepsis that can result of that too. So it's more common in 3 months to 6 years, but not so much that later in age. It's really more that 1 to 2 year old, more in the younger. So this is the telescoping bowel, and it usually occurs in that ileocecal area. So that small bowel will get pulled up into the colon. So think of the direction of movement. So stuff is moving through the GI tract and it's pulling that small bowel with it as it goes in. So it's proximal telescoping into the distal area. So, and that's important, I'll tell you when we get to fixing this. So that's going to be important. So the direction of flow is pulling that tissue with it, and it can pull some of that mesentery too, some of that tissue that holds the guts in place, right, that adheres on the outside of your bowel. It'll pull that in and cause a lot of discomfort. And some of that brings blood vessels with it, so there's decreased blood flow there. Right? So this nickel diverticulum and these intestinal polyps, that's what we might see with them. This is just a congenital, it's an attachment with the yolk sac in utero. That's just one of those pieces that doesn't disappear before birth. Some people have it their whole life, don't even know that exists, but they find with this intussusception, they tend to also have that, so it just, I don't know how it would contribute to it. It's just something that they found, oh, they have these polyps in this kid. So there's some connection in presence of those with this process. So here's a little better picture of it. So this is the direction of flow. So in this picture, so it's pulling that bowel up in it as things move along. And you can see it gets caught up in there. Here's your common area. So where it pulls it in with it as stuff's moving along into the colon. So this triad of symptoms. Abdominal pain, looks painful, right? Kind of reminds me of like those old water snake things as a kid. That, you know what I'm talking about, you hold on to it and it slips out of your hands and it just kind of telescopes into itself. Oh, okay, maybe it's an 80s kid thing. No. Or your finger, yeah, or you could take a glove. If you take a glove and fill it with water and you push the fingers in, it kind of has that same, that's kind of what's happening. Abdominal sausage-like mass. So I know we talked about the olive-like mass, but this is a longer mass and it's probably going to be in that lower right area versus that upper right. Bloody jelly-like, currant jelly-like. What is currant jelly? Is that a southern thing? I don't know. Anybody know? But it's that darker red jelly-like appearance. That's another NCLEX famous question. That's why it's red. Screaming, drawing knees to chest, that's that pain. Abdominal discomfort, that's what people want to do, is bring those knees up. Lethargy, vomiting, maybe with bile. It's lower, right? Lower GI. Diarrhea, why diarrhea versus constipation, or why are they both there? Can you think logically through that?
It's not an obstruction.
So, yes, you can have diarrhea and constipation with obstruction, right? Obstruction is going to create a constipation, but why the diarrhea? You get in there. You had an idea too? Go ahead. Yes, it's fluid trying to get around an obstruction too. So that true in this case, or any other type of constipation can sometimes have diarrhea, but it's small amounts because there's force behind that obstruction, and so whatever can get through, even if it's liquid, is going to get through with all that pressure that's building up behind it. So you can see both. Fever, probably from the inflammation, or unless infection is starting to occur, because there's all kinds of, you know, your gut is not sterile from mouth all the way through. It's not considered sterile inside your GI tract. So if there's any damage in there, infection can kind of get into your bloodstream and cause fever, which would be sepsis if it's systemic and high fever. Dehydration, shock, hypovolemic shock, perhaps. So these are later stages. Yeah, and it can be a sudden acute pain. It's not like a gradual onset. It hurts right away. So yeah, possible necrosis, decrease in blood flow will cause that tissue to die out, and potential perforation. That's where you get into sepsis, shock, fever, all that stuff. Okay, so this is imaging, this is ultrasound, and this is the angle of it. So it's looking at, if you were to have the valve this way and you're looking straight on at it, it looks kind of like a donut here. So this is the tissue pulled through, and this is the swelling that's occurring from the outer part of the bowel. So it creates this like donut look. So it's managed with, it says air enema here, with or without contrast. Usually they're just going to go right to a barium enema. So I just talked about that a little bit ago. So the diagnosis can also be the cure at the same time. So right as they catch it, whoops, they fixed it. So let me explain that to you. Let me back up a little bit to a picture. This one's kind of a good picture to show you, but this one's a little bit more close up. So remember the direction of flow that pulled this bowel into the distal area, into the colon? Well, if we're coming from the other end with an enema, with liquid that's got barium in it to x-ray, it's actually going to push on this piece as it flows in that direction. So it untelescopes it in the same process. Doesn't always work that way, which is where that air bolus comes from too. They'll push air into it to get it out of the way. Ouch. I feel like that would hurt. Although they would get relief because that pinching is, you know, just the whole process sounds awful. Question?
Is it likely for reoccurrence?
That's a good question. I don't know the incidence on reoccurrence. I don't think it does. It's just it's something that happens early on, and as their body grows and adjusts and things settle into where they're supposed to be, that it doesn't happen as often. But I don't know what the statistics are on that. Any other thoughts, question? I thought somebody else was going to say something. No?
It was my
Same question? Recurrence?
Yeah, because you've got this.
Yeah, you would think it would just go right back in.
It's growing.
Well, and it's likely inflamed too, so once you'll release that, it's probably gonna kind of stay out just from that inflammation and irritation that it just went through, so it shouldn't telescope right back in on itself. Because it's gonna create some swelling in there, and that might make a rigid surface once it's released. So, there's your jelly poop. So education, what are we going to talk about? We need to make them NPO, right? We don't want to create any more problems, have it, you know, we want to empty the bowel, rest the bowel. We might need an IV to rehydrate. If they've had a perforation, obviously we're going right to antibiotics, right? We want to prevent sepsis, make sure that infection doesn't get systemic or any, yeah. When you introduce bowel into a sterile environment, it's no good. NGT to LIS. NG tube, nasogastric tube to low intermittent suction. So we're decompressing the stomach. Did you guys cover that in P2 lab with the NG? They talk about why low intermittent versus continuous suction, maybe? No? Yes, maybe? Refresher, intermittent suction is so that whatever catheter you have in the Salem sump tubing or whatever you have in their stomach doesn't stay sucked up against the wall and creating some kind of ulcer on the inside of the stomach. So that low intermittent allows it to release from time to time, and as they move around, it won't suck up against the edge of the stomach wall. And we want it to low, that high pressure, we want it to suck up against a wall and cause that, basically a hickey inside their stomach, suck up and pull all the blood vessels, create an ulcer. So we're decompressing the stomach because we don't want that food to end up where our problem is, right? So we want to empty the stomach till we can fix the problem and let them start feeding again. So they're going to be blood mucus filled, so that's why it's mucus and blood prior to the procedure, and should become browner once the intussusception has reduced. So older blood, right? You know that bright red is new, dark red is older blood. Right? Pretty straightforward. GI's like, you can wrap your brain around it because you can visualize what's happening. All right, last topic, volvulus. This is another emergency. The other one is too. This is definitely an emergency. Not as common, but it happens. Malrotation of the intestine around the superior mesenteric artery. All right, so this is twisting of the small bowel around itself, and then that mesenteric artery, their superior inferior, gets pinched off in the process. So that's why this is purple, because we've got decreased blood flow to this area. So we're at risk for dead bowel here, right? Big problem. Needs a prompt diagnosis, upper GI series. What's that? Series, thinking x-rays, right? Upper GI x-rays. Surgery is your management. So if there's any dead bowel, they're going to remove that. If it's caught quick enough, they might be able to untwist. Very similar on your care, pre-op, NPO. Okay. Rehydrate with fluids, NG tube to suction, lower intermittent suction. Post-op, watching for infection, right? Now, depends on how much of their bowel was removed, right? They could be at risk for this short gut syndrome, so that's not just an adult thing. I've seen that a lot in peds. A lot of our kids that had a lot of defects, we see short gut a lot. They've had a lot of surgeries, and yeah, so they get a lot of frequent diarrhea, lots of fluid losses. Gotta keep them hydrated, keep those electrolytes going. The end. So I do have a couple of questions. Let me pull them out because we got a couple minutes. I'd love to let you guys go early, but I really want to, we didn't get to go over anything, question-wise. Okay, we're on the PEDS train. 18-month-old male is being assessed by the nurse for possible intussusception. Which of the following would be least likely to provide valuable information? You ready? Family history. This doesn't run in families, it just happens. We don't know why it happens, it just does. A nurse is assessing a child with pyloric stenosis. The nurse is likely to note which of the following? Pyloric stenosis, right? Yeah, these are easy, right? Good, I just went over it too. Thank you. An infant is diagnosed with pyloric stenosis, is admitted with history of vomiting for several days. Which nursing diagnosis would be the priority? History of vomiting, several days. Deficient fluid volume related to prolonged vomiting, ineffective airway clearance related to impaired swallowing, imbalanced nutrition related to prolonged vomiting, and anxiety related. What are your two?
A and C.
Okay. And you want A, right? So not that this one is not important, because we're gonna do this too, but we need to get these fluid and electrolyte replacement, that's the priority, right? I think that was it, and those, want some adult questions?
Yeah.
Okay, patient is with suspected irritable bowel syndrome asks the nurse about common symptoms. Which of the following should the nurse include in the response? So we've slept since then, right? Alright. Okay. Fever, bloody stools, abdominal pain and bloating, jaundice and weight loss. Did we even talk about jaundice yet? No. Nausea and vomiting with IBS. The pain and bloating. That was your, remember bloating before, right? Gassy. Which of the following is a key difference between ulcerative colitis and Crohn's disease? Ulcerative colitis affects only the large intestine, while Crohn's can affect any part of the GI. Crohn's disease is more likely to cause strictures and fistulas. You can skip right to D, right? Ulcerative colitis involves only the mucosal layer. You gotta be careful though too, just because sometimes these things can get switched. So this is true here, and Crohn's is transmural, remember, across the wall. So yes. Oops, wait a minute. How did that happen? All right, we got that one there. That's another all of the above. Patient with short bowel, increased risk. You guys would have gotten that anyway. That's right. When you try to put in all the little things, they disappear off of there. It's supposed to, yeah, see, it went backwards. All right. Which of the following medications is commonly used to treat both Crohn's and ulcerative colitis? Now we're getting a little more tricky, right? So you probably need some more time to look back at your medications to get more comfortable with this one, right? Saladine. Okay, so look at your meds, so you know, okay, I'm gonna look at that. And the meds are in your slides, right? For PowerPoint, they should be the same meds that are in the book as well. It's been a little while since I looked at the two. I might have dropped one or two off of my slides that might be in your book, so go ahead and look at the meds in your slides. And then your blueprint, when we make the blueprint available, we'll have what meds we want you to focus on. Now there could be some overlap, right? Of some meds that cover more than one topic, right? Immunosuppressants. Okay. Of course, because technology is not working for me these 2 weeks. So, okay, patient with IBS-D, diarrhea predominant, dietary modifications. Why B? Since we have the answer. Well, that too, but why specifically? It's gases, yeah. This is IBS too, right? So we want to reduce the gas producing particularly, right? We don't want to increase the fiber. That's with our constipation, right? Consume more dairy, eat larger, so it's the opposite of that, eat less, small, more frequent. Oops, see, that's what it was supposed to do. How does this, whatever. All right, a client is suspected of having ulcerative colitis. Which signs and symptoms should the nurse expect to find upon assessment? Why 20 bloody stools a day? What protocol does that come from? It's that diagnostic criteria. So, but it's in the count of the stools. So excessive amount of stools, that's your big clue. You don't even need to know the name of that. It's just part of that protocol includes how frequent those stools are. So you definitely want to ask them about that. Urinary stress incontinence, different topic. Hard, rigid abdomen, oral temperature. So none of them really point to it like that one does. Some of them work, some of them don't. Client is diagnosed with an acute exacerbation of ulcerative colitis. Which intervention should the nurse implement first? So read them all, because they're asking about first, so you want to make sure you read them all. Okay, any thought? Which one? They all rhyme. There you go. Right? Initially, right? First. So, NPO, or, on bowel rest for a little while, and we're going to gradually bring them back until, once we get those medications and that inflammation under control, then we can go ahead and start introducing back into their regular diet, which would be a low residue diet. That's what they're going to be on from here on, so forth. So here we go with a low residue or residual diet. For ulcerative colitis, which meal selection indicates the client understands the teaching? Don't you hate those questions? Which one requires further teaching? Which one tells you that they understand the teaching? So just be careful of those. Grilled hamburger on a wheat bun and fried potatoes. Chicken salad sandwich, lettuce and tomato salad. Nope. Roast pork, white rice and plain custard. Fried fish, whole grain pasta and fruit salad. Right. There you go. Lean meats, right? Not high in fat. So the fried fish, it's the high fat there. That's not so helpful for them. Okay. This client with ulcerative colitis is scheduled for ileostomy. The nurse is aware the client's stoma will be located in which area of the abdomen? Which one? So think about if their colon's removed and they're going to have an ileostomy. This is ulcerative colitis. So which part of the GI system is affected? Okay, so if we remove all of the colon, where does the colon and the small bowel end and begin? Okay, you got it? Sometimes you gotta map it out. And cardiac is fun that way too. Think about blood flow through the heart. It's all about directions. Which medications are commonly used in the treatment of Crohn's disease and ulcerative colitis? So these are your drug classes, right? So don't you hate these two? Select all of them. Ooh, which ones?
DEF.
See if this does it one at a time. Forgot C. Oh, you did? Okay, I thought you said D. Ha. Oops, that was it. So these others are with your IBs, not your IBD. Okay? Well, and the antacids aren't even mentioned because they don't typically have a reflux issue. Or the anticholinergics are with the irritable bowel syndrome. Okay? Good to go, guys? Have a nice long weekend-ish.